Because the goal of do is not success. It's learning.
This is Stepping Up Healthcare. Your host is Tack, and the mission is simple. Build your capability and curiosity to make healthcare better.
Welcome back. Today we're diving into something that sounds simple, but is often where improvement work either takes off or completely falls apart. We're talking about the P and the D of PDSA, the plan and the do. If you've ever been part of a project that felt chaotic, unclear, or like you're just trying stuff without really learning anything, chances are the issue started right from the beginning. So let's start simple. PDSA. It stands for Plan, Do, Study, Act. It's a structured way to test changes on a small scale or even for complex problems. It's pretty versatile when using it. But here's the key. Plan and do are not about implementing change. They're about testing change. That distinction, it matters. The plan phase is where we're answering a few critical questions. Some examples might be, what exactly are we trying to change? What do we predict will happen? Who will do it? When and where? And how will we know if it worked? That last one's huge. In improvement work, we often talk about a prediction. You're not just making a change, you're starting with what you expect to happen. If you remember from episode 1 of season 2, a problem is that gap between what we expect to happen and what actually happened. So you're predicting what you expect to happen. Here's an example. If we implement a bed shift report on one unit for 2 weeks, we predict patient satisfaction scores related to communication will improve. That's a plan. Not just, let's try bedside report. A real plan is specific, testable, and time-bound. Thinking about again that episode 1 of season 2, defining a problem, all the same theories and principles are used here. Now moving on from the P, plan, into the D, do. This is where you actually run the test. Now, if this is your first go at something, maybe you start small scale. Not hospital-wide, maybe not even unit-wide. Maybe it's just one nurse, one shift, one patient. And while you're doing it, you're not just doing, you're also observing. What actually happened? What went wrong? What surprised you? Because the goal of do is not success. It's learning. A failed do step is not that we didn't get what we expected. Thinking back to the previous example, we predict patient satisfaction scores related to communication will improve. And let's say they didn't. That's not a fail. A bummer for sure, because we didn't see any improvement, but that's not a fail. A failed do step is if we didn't learn anything. That's just a waste of time.
Why does it matter?
This is where a lot of teams struggle. In healthcare, we are wired for action. We see a problem and we fix it. Fast. And also, we have 17 different competing priorities, and taking an intentional moment seems counterintuitive. But skipping or rushing the plan leads to a variety of things. Vague interventions, poor adoption, no measurable results, and you're just running on vibes, and the frustration when, quote, nothing works. What's really happening is you're jumping straight to implementation without understanding your process or your system. And healthcare systems are complex. No duh, right? Think about something routinely done, like discharging a patient. It involves multiple roles, timing dependencies, communication handoffs, documentation. There are so many moving parts. If you don't slow down and plan a test properly, you're essentially running an uncontrolled experiment, or you're just running on a wish and a prayer. This is how PDSA turns into DDDD, or do. And in improvement work, that means you're not able to tell with any real certainty what caused the outcome. Was it the test we implemented? Was it complete luck? Was it the Hawthorne effect, where everyone heard we wanted to do better in a certain process, so they just started acting a little bit differently? Strong plan and do phases bring clarity and control into that complexity. They help answer a couple of questions, like, what did we actually change? Did it behave the way we expected? And should we keep going? That last question is key. PDSA isn't a one-and-done methodology. It is cyclical on purpose. We start with our plan, we do it, and then we'll talk about study and acting, but those are the next steps. And then you start back with the plan again. So thinking about, should we keep going in this path, or should we divert to a different path, or try something new?
Let's talk about some real-world examples.
All right, let's start with our first example, reducing patient wait times in an outpatient clinic. So, say a clinic notices long wait times and decides to try to improve it. A weak approach might be, let's redesign the whole schedule template. You just signed yourself up for a lot of work for something that might work. Instead, a PDSA approach might look like this. Our plan. Test a new intake process where a medical assistant starts intake immediately upon patient arrival. We're going to do this with one provider for one afternoon clinic. We predict that the average wait time will decrease by about 10 minutes. And we're going to measure time from check-in to provider entry. That's our plan. And then as we do it, our do step is going to look like run the test with that one provider for that one afternoon clinic. Do some observations and ask, did it actually happen as planned? And then capture any surprises. Maybe the MA got pulled into another task, or documentation slowed things down. Now you've learned something real. You've come away with some really good questions and leads to follow. How do you make sure that the MA doesn't get pulled into other tasks without disrupting the entire clinic? That's a good place to start. Next example, improving sepsis screening in the emergency department. Let's say an ED wants to improve early recognition of sepsis. Instead of sitting in a conference room and rolling out a new protocol or policy and just emailing it to everyone and calling it good, we're going to start with our plan. Our plan is test a screening tool with one triage nurse for one shift, getting their input on how to improve. Our prediction is that screening compliance will increase from 60 to 80%. And we're going to define exactly what compliance means. Now that's a solid plan. So what does our experiment look like? What does the do step look like? Well, first we're going to run the test. We're going to do observations and watch the workflow impact. And then we're going to capture barriers. Was the tool easy to use? Did it slow down triage? And then work with that specific triage nurse to gain valuable insights. They are the folks that are doing the work. Let them breathe into that process. All right, so let's zoom out for 1 second here. If plan and do feel familiar, that's because they are. They are grounded in the scientific method. PDSA just is the scientific method. The same framework you use in research and in your 6th grade science class. At its core, the scientific method is all about forming a hypothesis, that's your plan, testing it, your do, observing and analyzing results, that's your study, and refining your understanding, that's your act. That's exactly what PDSA is doing, just in real-world healthcare settings rather than a lab or at a workbench at school. So now, moving from hypothesis to action. In improvement work, we often translate a hypothesis into a very practical format. Personally, I like the if, then, as measured by format. This is one of the simplest ways to strengthen your plan phase and combat that inclination to turn PDSA into DDDD, or do. Here's how if, then, as measured by works. So, if we make this specific change, then we expect this specific outcome as measured by this specific data. Now let's take a vague idea here. We should improve discharge communication. Great, a need has been called out. Unfortunately, that's not very testable. Now, let's turn that into a hypothesis using the if, then, as measured by. If nurses use a standardized discharge checklist for one shift, then patients will better understand their discharge instructions, as measured by teachback success documentation in the chart. Now we have something we can actually test against and learn from. To make this even better, that as measured by maybe includes some actual hard data. So instead of as measured by teachback success documented in the chart, maybe it's as measured by 95% compliance of teachback success documented in the chart. So why does this actually matter? Without a clear hypothesis, your do phase just becomes doing stuff. You might run a test, but you don't know what success looks like. You don't know what to actually measure, and you don't know how to interpret the results even if you get them. You're honestly just going off vibes alone. A strong hypothesis statement creates focus. It forces you to be specific about the change, also to be honest about your expectations, and define success before you even start. And here's what's important here. Your prediction doesn't have to be right. In fact, it might not be, and that's okay. That's not a failure, as long as there is learning. So bringing it back to plan and do. So when you think about plan, think, what is my hypothesis? And when you think about do, think, let's test that hypothesis. Hopefully you see that shift from let's try something to let's test a hypothesis. This is what separates real improvement work from good old-fashioned trial and error.
Homework time.
All right, so we're going to pass out our homework assignments here. I want you to try on your next shift or the next time you're at work. I want you to pick one small annoyance in your daily work. Maybe it's a delay, a communication gap, a repeated workaround, something that happens fairly regularly. Now, let's make a plan. Define one tiny change. Decide where and when you're going to test it, and then write your prediction down and make a hypothesis statement. Now, keep it small. Think 1 hour or just one interaction. And then do it. Run your test, pay attention to what actually happens, and jot down 2 to 3 observations. That's it. You don't need a formal project. You don't need a project charter. You don't even need approval from any committees. You just need to start learning. It starts with those small, intentional tests. Plan and do are not checkboxes. They're the foundation of meaningful improvement. When done well, they turn guesswork into real learning, and that learning turns into better care. In the next episode, we're going to dive into the study and act. So we've done P and D, now we're going to talk about S and A. And that's where the real insight starts to take shape. All right, that's all I got for you. Little self-promotion here. If you haven't checked out my YouTube channel, make sure to do that. Got some content that's exclusive to YouTube that you can check out. Until next time, I'm Tack. You're appreciated. Let's step up healthcare.